I'm Dr. Priyankar Pal from Kolkata, India, and I'll be speaking on a practical approach to pediatric vasculitis. So, the truth about all clinical medicine, the mind is like a parachute. It works best when it's open. So, let's start with a case. We have a 15 years old male who presented with fever and cough of 3 weeks duration. For the last 2 weeks, he's having blood-streaked sputum and respiratory distress for the last 1 week. On examination, he is pale, his tachypneus, there's bilateral crepes, and he's hypertensive. Hemoglobin is low, there's neutrophilic leukocytosis, their CRP is elevated and it goes on rising. The coags are normal, blood culture is negative. And this is the HRCT chest showing bilateral diffuse opacities in both the lung fields. On day 7 of admission, he develops a hoarseness of voice. Laryngoscopy shows a glandular polypoidal swelling in the left vocal cord. Day 12, there's gross hematuria, and the child suddenly becomes a little swollen. And he develops rashes in the lower limbs. Urine shows features of nephritis, and there's AKI. So we have a patient who has multi-system involvement with a rapidly progressive glomerulonephritis and hypertension and bilateral lung bleeds possibly. So you investigate for collagen vascular disease. ANF is negative, complements are normal, and he is PR3 C anchor positive. So the diagnosis is that of GPA, granulomatosis with polyangiitis, which was previously known as Wegener's granulomatosis. So rule 1, suspect vasculitis in multisystem inflammatory disease. So when to suspect vasculitis? Fever of unknown origin, recurrent headaches, CNS and visual abnormalities, acute neurologic changes, a foot drop or encephalopathy, redness of eyes, mucositis, arthritis, rashes, recurrent abdominal pain, bloody stools, hemoptysis, breathlessness, chest pain, skin, you can have purpuric rashes, livedoid rashes, blood in urine, and not to miss out, hypertension. Recognize that the spectrum of vasculitis is broad, from minor rash with no organ involvement to a fulminating, life-threatening disease. So this is the CHCC 2012 classification for vasculitis, and then you have the Ankara Ozen's classification of 2006, which is predominantly for the pediatric age group, and which has also been, the EULAR and the press has endorsed it. So you have a predominantly large vessel vasculitis, medium vessel, and then the small vessel vasculitis, which is further subclassified into a granulomatous form and a non-granulomatous form. And then you have the other vasculitides, Behçet's, secondary to infections, and then you have an unclassified section as well. Rule 2, appearances do matter. And one must remember that rheumatology is all about pattern recognition. So you can have a patient presenting with a gangrenous limb because of vasculitis, where the diagnosis is very obvious, or you can have something as subtle as a livedoid rash like this child. Now, looking at the commonest childhood vasculitis, which has replaced IgA vasculitis or HSP, and now it's the leading cause of acquired heart disease in children. So, ladies and gentlemen, we are talking of an infantile or early onset fever, bilateral non-purulent bulbar conjunctivitis, mucositis. You can see very well the red, dry, cracked lips, which is a telltale sign. And you can have edema of the extremities, a rash of any kind except a vesicular or a pustular rash. Of course, it is Kawasaki disease. So remember that Kawasaki is a clinician's delight to diagnose. And these are the late features into the second week, where you can have the classical periungual discommation of the hands and feet. Do not forget the perineal and the perianal discommation precedes the periungual discommation. And occasionally you can have lymphadenitis, and sometimes the lymphadenitis may resemble also a suppurative lymph node. Retropharyngeal phlegmon, which is often confused with a retropharyngeal abscess. And this is almost pathognomic of Kawasaki, a BCG acceleration. This is something that we had described some years back, nail sign in Kawasaki disease, orange-brown coloration of the nails. And this is a finding which comes by 4 to 5 days, and it stays long. And now there are lots of literatures globally, and it has now been also described a valid sign in Kawasaki disease in children of different ethnicities. What is the importance of diagnosing Kawasaki? Untreated, 20 to 25% of these children may develop coronary artery aneurysms. And remember that this is the commonest cause of myocardial infarction in children. And this is one such child. You can see multiple aneurysms in the axilla. There's iliac artery aneurysms, there's renal artery aneurysms, and of course, you had the coronary artery aneurysms as well. And this is a neonatal Kawasaki disease. This baby had presented with fever for 7 days, and there were multiple aneurysms. And this is one of the earliest reported Kawasaki disease in the pediatric age group, the neonatal Kawasaki disease. The classic vasculitis, IgA vasculitis, the classic triad of rashes, pain, abdomen, and arthritis. Sometimes you can have this very angry-looking angioedema of the scalp and the genitals, and sometimes they can have testicular torsions, a testicular swelling, epididymoorchitis. The face is usually spared, but again, involvement of the face may represent a severe disease, and especially underlying renal involvement. The counterpart in infancy, the hemorrhagic edema in infancy. And occasionally HSP can have bullous rashes. Fever, hypertension, non-healing ulcers, autoamputation of the disease. This is polyarthritis nodosa, recurrent aphthous stomatitis along with genital ulcers. Of course, the diagnosis is Behçet's disease. Remember that lupus can have very, very atypical presentations, and vasculitis can have vasculitis, and especially with antiphospholipid antibodies, can have devastating presentations, like this patient who presented with a huge CNS bleed and sigmoid sinus thrombosis. Rule 3, a thorough clinical examination is the key to a correct diagnosis, and examination of blood pressure is mandatory. It's not optional. An examination of the eye can give a lot of information, and this is a very chronic persistent ENT disease. Of course, is a very, very rare entity, which is the EGPA or the Sachs-Frost disease. Rule 4, investigate rationally. So majority of the patients, like the patient that we presented, will have neutrophilic leukocytosis, thrombocytosis, anemia and eosinophilia, raised acute stress reactants, and of course, you will have the ANCA positivity in association with the small vessel vasculitis. C-ANCA is very specific for vaginous or GPA. P-ANCA is for microscopic polyangiitis, but you can have P-ANCA positivity in a variety of other diseases as well. Angiography is important, especially for large vessel vasculitis. So out of the mesenteric vessels, and this is the MR angio for a patient of Takayasu arthritis. MR angio of cerebral vessels in a patient who had presented predominantly stroke. You can see a CNS vasculitis over here, and of course, occluded left popliteal artery, and this is polyarthritis nodosa. Consider tissue biopsy of affected organs to determine vessel size and histologic features as well. So one must remember that an adequate specimen should be required and obtain immunofluorescence studies. So the specimen should always be sent in a normal saline. So in IgA vasculitis, skin biopsy is not mandatory. It is done when the diagnosis is less obvious. PAN, again, biopsy is diagnostic of PAN, and you can have the eGPA and the GPA, where you can have the posse-immune necrotizing granulomatous inflammation. Rule 4, beware of mimics. So this is a child who had presented with fever, high acute phase reactants, and this vasculitic rashes, only to finally have a diagnosis of left atrial myxoma with embolizations. So when to consider vasculitis? Mimics the red flags: presence of a heart murmur, splinter hemorrhage, so endocarditis, prominent liver dysfunction, history of recreational drug use, high-risk sexual activity, and a diagnosis of neoplastic disease. Ovarian malignancies can present with vasculitic rashes and very high acute phase reactants. Commandment. This is a commandment. This is not a rule. Thou should not forget infections, especially certain infections can present with vasculopathy, like the rickettsial fevers. And sometimes when a patient of vasculitis on immunosuppression can present with unusual infections, like this child who had presented with a miliary mottling in the lung and this unusual skin lesions, which was a disseminated cryptococcosis. Remember that HIV-associated vasculitis can masquerade a lot of rheumatic diseases. So final points to remember: when a patient has complex multi-system inflammatory picture, think of vasculitis. A lot of patients in PICU are actually patients of vasculitis. So if a vasculitic disorder is considered, search for the cause, employ tests and biopsies rationally. And remember, you are treating a patient and not the test. And rapid diagnosis and treatment is often organ as well as life-saving. Thank you.